Hello, and welcome to the next lecture in my OB-GYN Success podcast series. Once again, my name is Rashan Burns, and I'm a medical student at UC Irvine School of Medicine. This is going to go over OB clinic basics. So this is when a woman either first presents for her initial OB visit after just learning that she's pregnant, or presents for her routine OB checkup. Once again, I'm basing this off of our experiences at the UC Irvine Clinic, which is the family health clinic at Santa Ana, but most of this will also pertain to other clinic visits elsewhere. So for the first clinic visit, you'll have a woman who has just found out, probably via home pregnancy test, that she is pregnant. And it'll go something like this. Patient comes in with a positive home pregnancy test. Her last menstrual period was 6 weeks ago, LMP. So what do we need to do next? So first we need to confirm that she's pregnant, and we'll give her a urine pregnancy test in the office. Next, if she is indeed pregnant, we'll need to see where that pregnancy is. So we'll use ultrasound. So evaluation with ultrasound can reveal one of three things. It can reveal an extrauterine or ectopic pregnancy, and management for this includes two different options. Basically, you have to know that an ectopic pregnancy is a non-viable pregnancy, and ectopic pregnancy is most often located in the fallopian tube, and this presents great harm to the mother if it continues to grow, because the ectopic pregnancy can then burst the fallopian tube, cause very quick hemorrhaging, and shock to the mother. So basically, we want to terminate this pregnancy and remove it as quickly as possible. So the options for this include either medication or surgery. So the medication we most commonly use is methotrexate, and it can be used when the following criteria are met. The mother has to be hemodynamically stable. She can't already be bleeding. The mother has to not be on folate supplementation because this can interfere with methotrexate's efficacy. The mother should have normal renal, liver function, and also normal white count. And the gestation should be less than 4 centimeters on ultrasound, and beta HCG should be less than 8,000. Now, methotrexate is preferred because obviously it's not a surgery. It doesn't have the same risks that a surgery would, but if these criteria are not met, then the woman needs to be referred for surgery. So surgery just removes either going in and taking out the whole fallopian tube, especially if the pregnancy is already burst, or if the pregnancy is still kind of contained in the fallopian tube, then they can just go in, cut the fallopian tube, remove the pregnancy, and sew the fallopian tube back up. So now the next option for ultrasound evaluation is that you actually don't see any pregnancy at all. And this can be because the pregnancy is in an ectopic location that we just can't see, or the pregnancy is just not large enough for it to present on ultrasound yet. So if a beta HCG is less than 2,000, this is considered the discriminatory zone in which you can't actually see the pregnancy on ultrasound yet. So basically, if this happens, then we need to repeat the beta HCG in 48 hours and see how it changes. Normally, a beta HCG should double in 48 hours or at least rise significantly. So if there's a less than 53% rise, then this is considered an ectopic pregnancy and should be managed like such. Now, the last option is that we actually see an intrauterine pregnancy, and then that's when we begin pregnancy management, which is what the rest of this lecture will be on. So now we have an intrauterine pregnancy. What's our next step? We need to date this pregnancy. And there's two ways to date it. We can date it via last menstrual period, or we can date it via ultrasound. So to date via last menstrual period, you take that date, subtract 3 months, and add 7 days, and that gives you your estimated delivery date, EDD. You'll see that a lot. EDD is estimated delivery date. So for example, if the last menstrual period was April 1st, 2013, you subtract 3 months, so then you give January. You add 7 days, so you get January 8th, and of course you add a year because this pregnancy is delivering in the future. So, but we prefer ultrasound dating to last menstrual period. So our most accurate dating, and you'll get a lot of questions on this, is first trimester ultrasound. So first trimester ultrasound is accurate within 1 week of the actual delivery date. Ultrasound dating in the second trimester is less accurate. It's now accurate to within about 2 weeks. And third trimester is the least accurate. It's accurate to within 3 weeks. So the earlier we can get an ultrasound, the more accurate that dating will be. What we're actually measuring on ultrasound varies depending on when we are getting this ultrasound. So weeks 4.5 to 6, you'll be measuring normally the gestational sac diameter. Then weeks 7 to 14, you'll be using crown rump length, so it's from the baby's head to bottom. And then once you pass week 14, you'll normally take a bunch of different measurements and average those measurements together to get the estimated delivery date. So that'll be like measuring the head, measuring the abdomen, measuring the femur length, and then getting an average from those. But once again, we prefer like a gestational sac diameter assessment to this week 14 assessment. So now this is just an overview of the many different visits that a woman will have during her pregnancy. So these are all routine pregnancy screenings. This is not like, this is the very minimum we like to have women come visit us for. So I'll go into each of these into more detail. So when a woman first presents, or at weeks 10 to 13, that's when we do her first trimester screenings. So at first presentation, we'll do a hematocrit, blood type and screen, and including antibodies. And this is basically assessing for her Rh status and whether a woman who's Rh negative has already been exposed to Rh positive antigens. So if a woman is Rh negative with negative antibodies, she hasn't been exposed yet, and so then she needs RhoGAM prophylaxis throughout this pregnancy. Now, if a woman is Rh negative and already has positive antibodies, she's already been exposed and we can't prevent more exposure. So now the baby is at risk for fetal anemia and high drops and needs to be monitored closely. And I'll go more into detail on RhoGAM and Rh negative prophylaxis as well later. So included in the first initial visit screen, we also want to do syphilis screen, the RPR, rubella, hepatitis B, HIV, and also gonorrhea, chlamydia, tuberculosis screen, pap smear, and UA with urine culture. Now, just to mention about urine culture, they'll normally repeat urine culture once a trimester just to look for asymptomatic bacteria. So this actually occurs quite frequently in non-pregnant women as well, but we normally don't treat asymptomatic bacteria in non-pregnant women because it normally just passes and we don't have to worry about an infection. Now, in pregnancy, because there's ureter dilation and hydronephrosis risk, and then the woman is also more susceptible to pyelonephritis from an asymptomatic bacteria. So if we see this on urine culture, we'll treat even if they're not having the normal symptoms of a UTI. And then the first trimester serum screen also includes PAP-A and beta-HCG tests, which are basically assessing for Down syndrome. And this is the earliest Down syndrome test that we do. Now, weeks 11 to 14, we have another assessment for Down syndrome. This is the nuchal translucency ultrasound, and this is about 60 to 90% sensitivity for trisomy 21. So then moving on to 15 to 20 weeks, this is when we do the quad screen. So the quad screen is once again measuring for fetal possible anomalies, and it measures 4 different tests. So that's the quad: maternal serum AFP, estriol, beta-HCG, and inhibin A. And you can see here, depending on the results of this, it can mean different things. So if everything is low, then that's a sign of trisomy 18. If the maternal serum AFP and estriol are low, but the beta-HCG and inhibin A are increased, then that's a sign of trisomy 21. Now, it's important to note some other things can also cause increase in variations in these. So beta-HCG can be increased in twin gestation, as can maternal serum AFP. Likewise, if we have ultrasound dating from the second trimester, this might be a reason for increased serum AFP or beta-HCG just because it's an inaccurate dating and the woman might actually be farther along than we dated her. So that can just artificially cause a serum AFP increase or beta-HCG increase because these increase throughout pregnancy anyways. Maternal serum AFP can also be increased with abdominal wall defects and placental abnormalities too. Now, 18-20 weeks, you also do a dates and anatomy ultrasound, and so this is when they do a full assessment of the baby's anatomy on ultrasound, look for any abnormalities. They can also look for gender and stuff like that. This can also assess for Down syndrome and Edwards syndrome as well. So for Down syndrome, one of the key findings is an echogenic intracardiac focus, which is a calcification of the papillary muscles in the heart. And then for Edwards syndrome, choroid plexus cysts in the brain are pretty pathognomonic for Edwards syndrome. It's important to note echogenic intracardiac focus can be found on the dates and anatomy screen and then later regress and not be a sign of Down syndrome. So it just indicates need for more follow-up. Just to note about these screens for Down syndrome, these are all non-invasive screens. So if something comes up where now we're thinking that there's a higher risk for Down syndrome or some other trisomy or genetic abnormality, then we can offer what's considered invasive testing. So invasive testing includes chorionic villus sampling, which can be done earlier in pregnancy in the first trimester, or amniocentesis, which can be done in the second trimester. However, like I said, these are invasive. They require actually sampling from inside the uterus, and so there is a slight higher risk for miscarriage and for bleeding, and also mixing of maternal fetal blood as well. So next, at 24 to 28 weeks, we have 2 very important interventions. So the first is screening for gestational diabetes. So it's important to note gestational diabetes is independent from type 1 or type 2 diabetes mellitus. It can occur in up to 12% of pregnancies, and it's due to elevated levels of the hormone HPL that is present during pregnancy and causes insulin resistance, and so then it can create a new diabetes that occurs and arises just during pregnancy. So some people think, why do we screen so late in pregnancy for diabetes? Like, if someone has diabetes, shouldn't they present a lot earlier? So specifically, we're testing for gestational diabetes, and this arises late in the pregnancy around 24 to 28 weeks. So that's why we're testing now. If we tested earlier and the woman was negative, that doesn't mean she isn't going to develop gestational diabetes. So we might miss something. So to test for this, we're going to do a 1-hour glucose tolerance test where we give them a 50-gram glucose load, and then we measure the glucose after 1 hour. If that glucose is over 130 to 140, then that indicates we need to test further with a 3-hour glucose tolerance test. For the 3-hour GTT, we're going to give 100 grams of glucose, and we're going to measure at fasting before we give the glucose, then at 1 hour, 2 hours, and 3 hours. And the upper limits are given here. If 2 or more of these tests is abnormal, if they're greater than the numbers shown, then that indicates the woman has gestational diabetes. So management of gestational diabetes, obviously you want to try lifestyle modifications, including diet and exercise. And this can actually really help, especially because a lot of these women didn't have other conditions prior to pregnancy. So this can drastically improve their condition. Now, if we're still testing their sugars, we're testing 4 times a day, 3 times postprandial and 1 fasting in the morning. And if more than 25 to 30% of these glucose checks are elevated, then this woman is going to require insulin therapy. And so for insulin therapy, it's a little different from outside of pregnancy. They are going to do an AM/PM dosing of NPH insulin and regular insulin. Now, in addition to the glucose tolerance test, we're also going to check the CBC for anemia and give RhoGAM to women who need it. So we're going to give RhoGAM to all Rh negative women at 28 weeks. We're also going to give RhoGAM to any Rh negative mother who delivers an Rh positive baby within 72 hours of delivery. Likewise, we'll also give RhoGAM to any Rh negative mother with either a known Rh positive baby or a risk for having an Rh positive baby within 72 hours of any event that can involve mixing of their blood. So this includes hemorrhage, abortion, amniocentesis or chorionic villus sampling, an ectopic pregnancy, blunt trauma to the abdomen, or external cephalic version, which is when we use external manipulation to try and turn a breech pregnancy to the cephalic position. So it's important to note anytime a woman has any sort of bleeding, we need to know their Rh status because we might need to give them RhoGAM. So then our next assessment is at 35 to 36 weeks. We're going to do GBS testing. So if GBS is positive, it's valid for 5 weeks. So women who are at risk for preterm birth, like if they have a twin pregnancy, they may require earlier testing. And likewise, if a woman presents for post-term delivery at like 42 weeks and she was tested at 35, she may need repeat testing because that test might not be valid any longer. If a woman is positive, they're going to receive penicillin at time of delivery. Then at 36 to 37 weeks, we'll also do an ultrasound for baby's presentation. So baby can start presenting either cephalic or breech in like 34 weeks, but they can turn themselves. So even if we were measuring them as being breech in 34 weeks, they have enough room at that time to turn themselves until 37 weeks. After 37 weeks, there's less room in the uterus, so they're basically going to be in the position they're at 37 weeks when they deliver. So if a baby is still breech at 37 weeks, we need to try external cephalic version. And this is when, like I said, we use external manipulation on the belly to try and turn the pregnancy. Factors that can increase success of external cephalic version are non-longitudinal breech. So basically if the baby's like halfway breech, but still kind of close to being cephalic, we can turn them more easily. And also polyhydramnios or increased amniotic fluid, that gives baby a little bit more room to move around in. Factors that decrease success, on the other hand, are nulliparity, anterior placenta, low amniotic fluid, just because now there's less room to move, descent of breech into the pelvis. Once it's there, we can't move it. And also obesity, just because like anterior placenta, there's just more thickness in between the outside and trying to manipulate the baby. You're not directly hands on the baby. So that's an overview of what you'll be testing for at different clinic visits. Now I'm going to briefly go over what is the actual medical student's role. What are you actually going to do? So basically you'll see, like I said, a woman either for her new OB visit or for her return OB visit. So to start with her new OB visit, you're going to try and take a very thorough history. So you'll start with the date of her last menstrual period, or as accurately as she can tell you. You'll also start by asking whether or not this pregnancy was planned versus unplanned. While it's easy to get excited and tell a woman congratulations that she's pregnant, it's also important to note that 50% of pregnancies in the U.S. are unplanned, and that maybe this is not the news the woman was expecting or hoping for. So it's important to assess whether or not it was planned versus unplanned, and if you don't feel comfortable doing all the counseling required, you can also tell, but it's important to at least tell the resident, hey, this woman actually wasn't planning on getting pregnant and this is a surprise, so they can counsel her on her different options for this pregnancy. Now, also going along with an unplanned pregnancy, it's important to know what sort of medications the woman was taking and whether or not she was taking her prenatal vitamins. So for a woman who wasn't planning on getting pregnant, she may not be taking prenatal vitamins, and it's actually very important to take prenatal vitamins prior to getting pregnant, especially for like folate supplementation and stuff like that. We want folate supplementation to begin 3 months before a woman gets pregnant. So if she's not planning on getting pregnant, she may not have been supplementing this. Likewise, a woman who was not planning on getting pregnant or not expecting to be pregnant might be drinking alcohol, smoking, using recreational drugs during this pregnancy before she realizes she was pregnant. And this is an early time when a lot of organogenesis is happening, and so it's important to know what kind of toxin exposure this baby may have had. Now, it's also important to get obstetrical history. So this is very thorough, past pregnancies, deliveries, asking dates, genders, gestational age at delivery, mode of delivery, prenatal or postnatal complications, because sometimes some of these complications can then further predispose you to repeat complications in the next pregnancy. And likewise, C-sections versus vaginal deliveries can predispose you to certain complications as well. So this goes along with calculating your G's and P's. So normally every pregnancy presentation will be like something like 27-year-old G4 P3 at 36 and 4 weeks, which means 36 weeks and 4 days, presents with blah, blah, blah. So how do we calculate our G's and P's? So as you can see down here, so a G is how many times the woman's been pregnant. This is any sort of pregnancy with any sort of outcome. So just how many times was she pregnant. Then P is the outcome. So you may have learned P's as being like, what I said, G3, P2 or something like that. But actually it's more expansive than that. We're going to be like G3, P2, 0, 1, 2. So what does that actually mean? So the first P is term deliveries. So if we have G3, P2, 0, 0, 2, that means that she had 2 term deliveries. The second P is preterm deliveries. So this woman, our G3, P2, 0, 1, 2, had no preterm deliveries. Now, the third P is spontaneous abortions, miscarriages, or therapeutic abortions. So our G3, P2, 0, 1, 2 had either an ectopic pregnancy, a miscarriage, or an abortion. So we need to further ask what was that, and also when in gestational age did that pregnancy end. Just an important side note, a miscarriage or ectopic pregnancy or an abortion after 20 weeks is actually considered a preterm delivery rather than a spontaneous or therapeutic abortion. Now the last column is living children. So in our, once again, G3, P2, 0, 1, 2, her 2 term deliveries then correspond to 2 living children. Just a side note, twins always confuse me. Twins are 1G, 1P delivery, but then 2 living children. So next we have our return OB visit. So this is every other visit that a woman is coming in for during her pregnancy. So these are very fast. Normally they're just checkups. There's nothing really going on wrong with the pregnancy. They just need to be checked up on. So you do a quick history, checking for vaginal bleeding or vaginal discharge, checking for loss of fluids, hopefully there isn't any, checking for fetal movements. So quickening refers to when the woman can start to feel the baby move, and this normally happens around 18 to 20 weeks. So starting 18 to 20 weeks, you can start asking a woman if she's starting to feel fetal movement. Around 26 to 28 weeks, fetal movement is so consistent that a woman should be able to fetal kick counts. And so this is 10 kicks per 2 hours at least is what we're hoping for. And then starting in the 3rd trimester, we're also going to start screening for symptoms of preeclampsia and HELLP syndrome. So these include headache, right upper quadrant pain, blurry vision, and edema. And just a note, preeclampsia is when you have really high blood pressure during pregnancy, and then you can have protein in the urine. This can predispose a very high risk for then developing eclampsia, which is all of these things plus seizures, and it's very high mortality risk for the mother and the baby. So it's important to start screening for these things early. So once again, these signs are headaches, right upper quadrant pain, blurry vision, and edema. Next, you'll do the physical exam. So the physical exam in a return OB visit is going to include getting the heart tones, and this is going to be done with a Doppler ultrasound, which is there's going to be ones right outside each room in the clinic, and so you just grab it, place it on mother's belly, and listen for fetal heart tones. Normal fetal heart tones are 110 to 160 beats per minute, so it's quite fast. The best place to find fetal heart tones is the lower right and left quadrants on the mother's abdomen, and generally more midline than lateral, and then you can kind of just feel around. It's important to distinguish between placenta heart tones and the actual fetal heart tones. Placental heart tones will be a little bit more diluted and less crisp because of all the blood flow that's going through the placenta, versus a fetal heart tone from the heart itself is going to be very crisp, clear beats. If you can't find the heart tones from the heart, placenta is good, but it's not as direct a measurement as the heart itself. And then it's important to note, if you're getting heart tones of like 60s or 70s, you may actually be picking up the mother's heartbeat. So it's important to feel around and move locations to try and find the baby's heartbeat, actually. So the next thing that you're going to measure is fundal height. And so this you can start doing after 20 weeks. And so you'll take a little tape measure and put one end on the pubic symphysis of the mother, and then go all the way vertically up to the top of the fundus and feel for how far up the fundus is. And then that measurement should correspond with gestational age. So a 32-week pregnancy should have a fundal height of about 32 centimeters. And this is accurate to within 3 centimeters or 3 weeks. So basically, a 32-week pregnancy should have a fundal height between 29 to 35 centimeters. If fundal height is much lower than that, that can be a sign of intrauterine growth restriction, or IUGR, intrauterine growth restriction. So then lastly, starting at 34 weeks, you can start measuring fetal presentation. But like I mentioned, this won't be fixed until 37 weeks. So it's just something to monitor. So that's it for the Clinic Success podcast. So once again, good luck on your OB-GYN rotation.